Hello class! Today we will be talking about febrile neutropenia and the steps to be taken when treating patients with a neutropenic fever. Neutropenia is the greatest risk factor for developing an infection in cancer patients undergoing chemotherapy treatment due to the fact that their body is unable to fight off infection. A fever is often the only sign of infection in a neutropenic patient. Nearly one-half of patients with febrile neutropenia actually have an infection, and at least one-fifth of patients that develop a neutropenic fever have bacteremia. Neutropenia is defined as having an absolute neutrophil count, or ANC, of less than 500, or 0.5, or less than 1,000, or 1.0, which is anticipated to decline to less than 500, or 0.5, within the next 48 hours. Fever in neutropenia is defined as a temperature of 38 degrees Celsius or greater. It is imperative that the nurse take action when his or her patient develops a neutropenic fever. Patients in the outpatient setting are instructed to go to the nearest emergency department when they develop a temperature greater than 38 degrees Celsius at home. For patients in the inpatient setting, several things need to occur. An assessment of the patient should be done to look for other signs of infection, and the provider should be notified. Do not forget to document your assessment findings in the electronic medical record. Guidelines for culturing is as follows. If there is no central line present, 2 peripheral cultures should be drawn. If there is a central line, and the line is greater than 5 days old, 1 peripheral culture should be drawn, and 1 culture from each port on the central line should be drawn. These should all be marked very specifically prior to sending them down to the microbiology lab. For persistent fevers, peripheral blood cultures should be drawn every 24 hours. Along with the cultures, a urinalysis and a urine culture should be sent. A gram stain should be requested. A chest x-ray should be obtained to look for signs of pneumonia or infiltrates. If diarrhea is present, a stool sample should be sent to rule out C. diff. A respiratory viral panel should also be sent if the patient is exhibiting respiratory symptoms such as a cough, sneezing, or drainage of the nasal passages. Treatment. Cefepime is the initial antibiotic therapy and should be administered within an hour of the first fever. This is a change from the previous standard of Zosyn. Vancomycin should not be utilized as an initial antibiotic. It should only be used in special cases, such as evidence of gram-positive infection, hypotension, and/or a suspicion of pneumonia. If the fevers persist for greater than 96 hours and there is not an identified source of infection, transplant infectious disease should be contacted. If there is concern for an invasive fungal infection, transplant infectious disease should be contacted. Patient response should be evaluated every 3 to 5 days. The patient can be taken off of their antibiotic regimen once fever is resolved and they are no longer neutropenic if there is no identified source. If there is an identified source of infection, the patient must complete their treatment for the infection based on the standard guidelines. These guidelines are based on the standards of practice for Strong Memorial Hospital. Your institution of practice may have different standards of practice. Please review your institution's guidelines prior to enacting.